To better understand this disorder, it is first important to recognize how it is categorized within the DSM-5. Pedophilic disorder is described as one of the 8 paraphilic disorders, which are defined as intense and persistent sexual interest other than what is defined as normal. Specifically, pedophilic disorder is an ongoing sexual attraction towards prepubescent or pubescent children, and pedophiles that offend either sexually molest a child or partake in the production or distribution of child pornography. To be diagnosable, the pedophile must be at least 16 years of age or 5 years older than the child. To work toward treatment with this population, it is helpful to have a firm grasp on what normal and healthy sexual behaviors look like and how they are possible. The APA describes normal sexual behaviors as sexual interest in genital stimulation or preparatory fondling with phenotypically normal, physically mature, consenting human partners. But to better understand why this isn't always attainable and how it can be, we can look to the Bible. The first 2 chapters of Genesis reveal how mankind was made in the image of God, and the woman was provided to the man because it was not good for the man to be alone. The partnership was formed because God designed us to be in relationship. Because the design was perfect, Adam and Eve lied together as man and wife and were naked but felt no shame. Normal sexuality within the marriage relationship does not experience shame, but when the relationship is unhealthy, so is the sexuality. Sadly, because of the fall of man, relationships are often broken and used for selfish gain, like with this disorder. As mental health professionals, we should care about this issue not only because it affects the person with the disorder, but it also affects the child victim of sexual abuse, with whom many counselors will work. Of the 4 million children who experience this abuse yearly, 50% of the sexually abused children have a perpetrator with pedophilic disorder. Unfortunately, many of these survivors of sexual abuse go on to experience long-term negative outcomes such as academic challenges or learning disabilities, PTSD, dissociative identity disorder, depression, eating disorders, partner violence, and physical health problems. In addition, many of these victims may sexually abuse their own children, repeating that same cycle of abuse. Next, the prevalence rate among men will hopefully urge mental health providers to fight against the course of this disorder. Hopefully, this information will also begin to increase the research that is being done to learn more, because it is currently not a strong area of research or advocacy focus. Due to the increase of neuroimaging techniques such as fMRIs, we're now able to complete more research on the neurodevelopment of people with this disorder. Unfortunately, research is limited and unclear due to several methodological challenges when faced with collecting a group of people with pedophilic disorder. However, this imaging has been able to note definite neurological differences between people with this disorder and without. First, research shows that those with pedophilic disorder are exposed to a higher level of androgens, such as testosterone. When fetal exposure to androgens is high, the child is likely to be left-handed and have a certain index to ring finger ratio. This is important because high levels of fetal androgen exposure may be predictive of impulsive behaviors. To some extent, the development of pedophilic disorder may also be more likely when considering heritability, epigenetics, and life events. Childhood trauma, such as sexual abuse, is one life event that may predict the likelihood of this disorder. Research also found in one study that people with pedophilic disorder experienced multiple head injuries before the age of 13. Lastly, lower IQ and shorter stature have been common to many of the subjects studied. For the brain of the person with this disorder, there is an obvious neurotransmitter imbalance, causing higher than average levels of serotonin and lower than average levels of dopamine, which then result in the increase of sex drive. Structurally, fMRIs show that the amygdala and hypothalamus of those with this disorder are smaller than average. The amygdala is responsible for emotional learning, while the hypothalamus controls many areas, one being sex drive. Some treatment considerations to keep in mind when working with a client with pedophilic disorder is that in nearly all cases, the person with pedophilia is either mandated to attend treatment as part of a court order or on the advice of a defense attorney following an arrest. Most cases are mandates because most are unwilling to face the embarrassment and legal consequences of their disorder. For those who seek therapy, if they have committed any crimes, those would have to be reported, which would lead to an investigation. However, if they choose to continue therapy, there are treatment options in many jail settings if the investigation does send them there. In addition, before a treatment plan can be developed, a thorough psychosexual evaluation must be completed. Since many of these questions would be difficult for the client to answer, such as how many victims or the ages of victims, many therapists use a polygraph test to get the honest disclosures. Treatment options should include both psychotherapy and medications. One of the most effective ways to alter any human behavior is through aversive conditioning. In pedophilic disorder, it uses a negative stimulus paired with inappropriate sexual arousal to reduce or eliminate sexually deviant behavior. In some examples, the negative stimuli used is shocking the client or having them smell feces while experiencing the problem behavior. Another treatment option is arousal reconditioning. The client is conditioned to be aroused by appropriate sexual stimuli, so it is kind of the opposite of what aversive conditioning is doing. But it's important to remember that aversive conditioning and arousal reconditioning might eliminate the behavior quickly, but it does not solve the root of the problem. So to decrease recidivism rate, the counselor should also address cognitive distortions, self-esteem issues, socialization difficulties and communication patterns, lack of coping skills, and impulse control. All of these are commonly found in someone with a disorder, and a couple of examples of ways these are addressed are empathy training and CBT. Often the person with a disorder needs to gain an empathy for the victim of their crime and the consequences from that. CBT teaches the client to recognize fantasies and urges when they surface and write them down along with the consequences of acting on those urges. Another important treatment is the follow-up treatment. After treatment, there should be an extended period of close monitoring in addition to extensive social supports. For these individuals, there are long probationary periods where the therapist can work closely with an officer who provides supervision and support. Two major kinds of medications are used for this population. The first group is anti-androgens, which reduces testosterone level and curbs the sexual appetite. It increases accountability as it has to be administered by a psychiatrist monthly via injection. The other medication type is antidepressants or SSRIs, which decrease libido and deviant sexual thoughts as well as obsessive compulsive acts. This decrease in libido can eliminate sexual fantasies, which usually leads to impulsive sexual acts.